So welcome. I'm Edward Skidelsky. I'm the director of the Committee for Academic Freedom, strange echo, which is a campaign group that was set up a couple of years ago to defend free speech in UK universities. As part of our activities, we run a series of events called Open to Argument, where we discuss controversial topics that aren't usually discussed in universities, but we feel should be. So this is one of them. We've also had debates on the Ukraine war, on Trump's presidency. We've got one coming up on Islamophobia. Without any further ado, I'll turn you over to Gunesh Taylor, who's come all the way from Edinburgh, where she researches genetics and embryology. She's also a prominent public promoter of science, has done many events at the How the Light Gets In Festival and elsewhere. Okay, thank you very much. Over to you.
Edward. Fantastic. Good evening and welcome, ladies and gentlemen. Tonight we are here to examine one of the most challenging periods in modern British history. The COVID-19 pandemic forced governments worldwide to make urgent decisions in the face of scientific uncertainty, and Britain was no exception. The COVID inquiry has officially become the most expensive in British legal history, £192 million and counting according to October's financial statements. So, what did Britain get right? What did it get wrong during the COVID-19 pandemic? Britain's response saw notable successes, including world-leading vaccine development and rollout, large-scale testing, and measures intended to protect the NHS and reduce severe illness, all arguably actions that prevented worse outcomes and brought vital time for scientific progress. But the response also revealed serious challenges. Debates continue over the timing of lockdowns, the situation in care homes, the clarity of public messaging, and even the methods used to measure COVID deaths. Of course, none of us can deny that the social and economic costs were in fact spectacularly significant, affecting healthcare backlogs, education, mental health, and civil liberties, to name but a few aspects. As we look to the future, key questions remain. How can we balance public health with individual freedoms? Could alternative approaches, such as focused protections, play a role next time? And what lessons should guide Britain's preparation for future pandemics? Tonight's discussion is an opportunity to examine these questions openly, fairly, and constructively. It is an invitation to us all to consider both sides of this complex picture, acknowledging achievements, recognizing mistakes, and learning from both such that we can better prepare for the challenges that lie ahead. To guide us through the complexity of this subject, we are delighted to be joined this evening by Sunetra Gupta, who is a professor of theoretical epidemiology at Oxford University. She specialises in infectious disease modelling and vaccine development and has published widely on the evolutionary dynamics of pathogens. She's also a signatory of the Great Barrington Declaration. We're also joined by Toby, who is a professor of African history at King's College London, with expertise in the history of inequality and pandemics. He is the co-author of COVID Consensus, The Global Assault on Democracy and the Poor, a Critique from the Left. We're also joined by Hugh Montgomery, who is Chair of Intensive Care Medicine at UCL London, and he has frontline experience managing COVID-19 patients in ICUs and has contributed to research on respiratory failure, critical care outcomes, and pandemic preparedness. And last but by no means least, we're also joined by Mark Honigsbaum, who is a medical historian and journalist who writes on pandemics, public health, and the history of medicine. He is a senior lecturer in journalism at City St George's University of London and is the author of The Pandemic Century, A History of Global Contagion from the Spanish Flu to COVID-19. So this evening, we're going to dive into all of these subjects, but before we get really into the heart of the debate, I wanted to ask everybody on the panel to make a couple of opening comments, particularly addressing the following question, or statement more appropriately. Name one thing got right and one thing done wrong during the COVID-19 pandemic, in your opinion. Sunetra, you first, please. If you could all just turn on your microphones, if you haven't already done so. Fantastic.
I think that's on there.
Thank you so much. 2 minutes, Sunetra.
Thank you, Ganesh. I'm going to start with what we got wrong, and I think what we got wrong, what I'm going to pick is, what we got wrong was that we thought we could stop the spread of COVID. This is a fallacy that derives from the misapplication of a particular type of logic. There are obviously circumstances where non-pharmaceutical interventions can keep a pathogen out, or indeed where you can apply lockdowns to keep a pathogen in, something I often call the noble lockdown. So we know about during times of plague that the villages would shut down to keep plague from spreading out. But what is very difficult is actually to, once a pathogen is in, to apply those measures to keep it from spreading. So that's one point. The second point is that there are ways of reducing individual risk. And we know that if you stay at home and reduce your contacts, you will reduce your individual risk. But this doesn't scale up. So, for example, you can keep a weed-free patch in your garden by tending it carefully, but it's very hard to pull out all the weeds. That one daisy that you leave there will, when you wake up, have smothered your lovely grass again. So, and that will happen unless you manage to plant some form of resistant grass. And what happens, which brings me to another related point, which we got wrong, which is not just that we thought we could stop the spread. The other thing we got wrong is the idea that we should have stopped the spread. Because when you stop the spread, what you do is you prevent, effectively, the grass becoming resistant. In other words, you prevent immunity from building up in the population, and that is what actually eventually brings everything to a more stable state. So the question then is, what should we have done if we couldn't stop it from spreading, or if there were big questions hanging over that? And the answer to that was that we could have just guarded those small patches. We could have, right at the outset, not locked down harder and faster or quicker, but actually started by protecting the vulnerable. Which brings me to the final point. What did we get right? Vaccines. Vaccines were developed at speed, which did protect those who were vulnerable to severe disease and death. However, because we were stuck in this idea that we could stop the spread, that's what the vaccines were sold as being able to do, which is stop the spread, when in fact that's not what they could do. What they could do, and they did do hopefully, is to stop people from dying through focused protection of those who are vulnerable. Sorry, was that more than 2 minutes?
No, that's all right, not to worry, Sunetra. Mark, what do you think? One thing right, one thing wrong, please.
One thing right, one thing wrong. Okay, so you've already said vaccines, so I didn't have to say that. Mm-hmm. I think one thing we did get right was once we decided that we had to lock down, that there was no alternative because of the danger of NHS critical care wards being overwhelmed. I think we got the messaging there right. Stay home, save lives, protect the NHS. And I think in that first phase, that was a message that the vast majority of British people could sign up to. Because, people were scared and panicked by the modelling. We can come back to that. But that was a very clear message that everyone could understand. That, if you want to give doctors the best chance of treating people with severe infections, and given that we have a very low number of ventilators per head of the population, this is something that people could be persuaded to do. And I think that people could be persuaded to do that without compelling them to do that. Indeed, I think that most of the British population were happy to go along with that, at least in the first phase. And indeed, we saw people clapping for carers and all that sort of stuff. And they're doing one thing we got wrong. I think the fundamental thing that we got wrong was the assumption before the pandemic that we could not suppress a respiratory pathogen. And it was worse than that. If you look at the pandemic plans, and I wrote a book on the 90th anniversary of the Spanish influenza in 2009, where I looked very closely at all the pandemic planning. And those plans assumed that we wouldn't be able to stop something like over 800,000 people dying in the event of an influenza pandemic. There are all sorts of reasons for that. But I think that assumption was ethically and politically flawed, because it wasn't until the reality actually hit that we saw modelling saying as many as 500,000 people could die, that everyone took a step back and said, we can't allow that to happen. We need to do what we can to save lives in this sort of critical situation. Had we thought about that more deeply, then perhaps we could have had a better plan than the one we did. We really didn't have any plan for suppressing COVID. It was all about mitigation. Indeed, I remember in some of the influenza planning, they talked about having mobile mortuaries or turning Lord's cricket ground into a mass mortuary because there would simply be so many dead people. So the problem became not saving lives, but how best to dispose of the dead. And I think that was a fundamental moral failure. I think it was a failure of imagination, actually.
Interesting. Hugh?
Oh, I could give you a long list, but I won't. I think the bit we got right was actually little to do with COVID to start with. It was the way we'd set things up. We had good public health surveillance, better than many in the world. We still had Public Health England. It had its flaws, but it did a pretty good job. We had an NHS, thank God, because I have many friends in other countries, and it was very, very different there. We had clinical academics. Very unusual. We don't get many of them in other parts of the world, but we had people who not only saw patients, but did research, and they knew each other because they were part of that network. And that meant that we could solve things more quickly on a clinical front line than others could. So we were able to dismiss a lot of what we heard from China and Italy and get it right literally within 24 hours. So I think we did well there. I think we were wrong with the rest of the world in not noticing early enough or not taking notice enough of how this disease was spread. Because there was, if you remember the early days, it was droplets and you stay 2 meters away, it's fine. And yet we'd seen the data from that bus in Wuhan, we'd seen the data from call centres in Korea showing it was aerosol spread. And yet we went down a line of industrial PPE, which wasn't necessary. It was using kit designed for bloodborne diseases and Ebola. And we got fixated on that sort of behaviour and we ignored some of the simpler public health stuff that might have worked better if we paid attention to it sooner.
Interesting. And Toby?
Yeah, thank you. What did we get wrong? I think there are a number of things we got wrong, but I think cost, £192 million on the COVID inquiry, but the general total cost is hard to know, but it's estimated between 310 and 470 billion pounds. So while the focus is on the cost of the COVID inquiry, that is a considerable order of magnitude higher. And whether it achieved anything, we can discuss later. I think the fundamental thing we got wrong, actually, is not having events like this. And I want to thank my fellow panelists, for being prepared to, discuss this openly. I think, what we all can agree is that 2020 saw a complete shutdown of various things, including the space for public debate, including the space for public discussion. So we may have strong disagreements about things on this panel, and that's to be expected. But we're all willing to come here and discuss them and try and understand each other's point of view and try and therefore understand our own points of view better. And the fact that the media space for that was completely closed down was a fundamental mistake, which created the space for, in fact, mistrusting government, which followed, the rise in populism, which has followed, and all of that was due to the attempt to micromanage information so fundamentally by governments all over the world that, in fact, what that created was a space, in the end, very quickly for complete misinformation. Things which, now there will be disagreements, there are disagreements on this panel around, for example, the origins of COVID, but the fact that social media companies shut down throughout 2020 and closed accounts of people who said it could have come from a lab in Wuhan, whether or not it did is another question, I'm not qualified to say so. But there still is a live debate around that, and the fact that people's accounts were closed down about that was has turned out to be, again, a driving factor in populism and misinformation since. So those were fundamental mistakes. So I'm grateful to everybody for being here this evening. What did we get right? That was a bit harder for me to think about and reflect on. But I came up with the decision not to lock down in December 2021, when there was a big pressure to do so. Modelling projections in The Guardian reported potentially 2 million cases a day, if you look at the headline, by New Year's Day. In fact, the peak was at around a little over 200,000, so it was an exaggeration of 1,000%. Had we locked down, as one of my students said at the time, I'll be doing my classes on the stairs again, and the regressive impacts of those lockdowns on education meant that the Southern Trust report in 2022 said that we had lost 10 years of progress in eradicating socioeconomic inequalities in education, and that would have been exacerbated by that decision.
Quite. Okay, well, there's lots and lots of food for thought there. Just as a quick reminder to everybody in the room as well, if you've got your phones on you, please can you pop them onto airplane mode, just to not interfere with the recording. Okay, so we've touched on a lot of different things here. I think that, so where I'd like to start is an acknowledgement of the fact that this has already been alluded to a little bit, I think, that there's a difference between what happened in lockdown 1 versus what happened after that point. And I think that that's an important thing to flag, actually, that what you do in the immediate face of a threat might not be necessarily what you need to do once you've made an assessment of the threat. And I think a few of you have sort of touched upon questions of, you know, whether or not we noticed the spread mechanisms appropriately, or the assumptions that we were making about how these kinds of things are. So there's clearly some questions about our assessment of what was actually going on. I don't want to be the person who's talking the most here, so what I would like for you to sort of discuss first off is basically, what are your thoughts on the actual measures that were taken initially versus later? So questions like, maybe Hugh, you can start us off. You mentioned already this idea of PPE. So we went from, you know, yes, face masks, no face masks. That was a big one for a lot of us. Why don't we start there?
Okay, so I can give you, so to be clear, I very much welcome your comments, because I also think the COVID inquiry as it is I'm not a fan of, because it's not encouraging proper live debate of, and I don't come here with a clear view of what was right and wrong, actually. I still don't know. I'm still conflicted. At the time, I think you were right, that at the time we knew we were in terrible trouble. We had, over Great Britain, around 6,000 intensive care beds. We had around 4,000 or more in England, which got mostly hit. 80% were full, and we were getting 400 admissions a day. And those 400 weren't evenly spread. They were hitting major centres. I went to work on a Friday, we had 1 admission, and we were tubing someone every 40 minutes. And just racking up people in bed spaces, without equipment, without drugs. It was an absolute tsunami, and that rippled its way through. At that point, if we had let it run, we would have ended up overwhelmed completely. We were overwhelmed, actually. We had veterinary nurses, dental receptionists, and the nursing staff, I should make clear, were the heroes of the piece. They were absolutely extraordinary, and what they faced was horrible. So I don't think we had much choice at that point, for the reason you said. We didn't know what was coming, and what we got was not what we'd been sold. It was very clear this was not just flu on steroids. This was a very different sort of disease that was systemic, affected multi-organs. We had to manage things in a very, very different way than we'd been expecting. As you say, people had planned for a H1N1 flu virus, and this was anything but that. So I suppose that was the right thing to do. The PPE bit, I agree, I think we alluded to earlier on. The playbook for PPE had been lifted out of American handbooks that were largely military handbooks, largely related to bloodborne viruses, which demanded long-sleeved, full-length, water-repellent, really uncomfortable gowns with double gloving, taping of wrists, all the things that you would do if you could get a virus through your skin. And yet we had frontline staff, GPs, nurses and things, without respiratory masks protection to start with. And we took our eye off the ball there, so I don't know, I think that's where we start from. If you wanted to start the ball rolling, I think the first decisions were the right ones at that point. If we had let it run, which I will just finish on, if we had let it run, we haven't yet had the public debate, we still have not had the public debate about death in this country, about the fact that we will all die, no one gets out here alive, that the elderly are more likely to die, those with comorbidities are even more likely to die, and we still have a disparity on my own intensive care unit where we'll have people who have no brain function left at all, and we'll have family members that would want them to be ventilated for 30 years, and others who will die very much earlier on, and we haven't had that debate. Sorry.
No, definitely. I mean, I really want you four to get into this. So, I mean, there's the death thing. Sunetra, are you in agreement? I feel like you were saying that the sort of concept of the stop the spread was wrong from the start, so you don't necessarily
No,
agree.
I don't agree, but what I want to talk about, so I think what we all agree on is that we needed to protect people from dying. I mean, that's what we wanted to do. And I think, as I said, the fundamental fallacy here is, in my opinion, the fallacy, which I think is now borne out by data, is that you can't actually stop something from spreading. So, but you can protect the vulnerable. So we now have data for both of those. But what I really want to bring out is that at that point, there was a lot of uncertainty. So we're disagreeing on something right now. And that's fine. I think I've got data that shows that you can't stop a respiratory pathogen from spreading. Mark, you obviously believe that you can.
No, I don't. I think you can slow it.
Or even slow it, whatever.
Yes.
I don't think you can slow it unless it's come up to very close to endemic equilibrium. But, let's just say at that point we didn't know. Maybe it could have been possible in theory. What we were obligated, I think, to do is to find a policy that was robust to these uncertainties. We took a gamble that lockdowns would stop the spread and thereby would protect, slow the spread.
Which it did.
Which it didn't. But it doesn't matter. It doesn't matter. Let's say it could have or it might not have. No, it didn't. But, no, I mean, it didn't. It's not. Let's just say in March 2020, we didn't know whether it would or not. Okay? We can agree on that. But what we did is we took the gamble that by slowing the spread, we would stop the deaths. Whereas what we could have done is had a policy that was robust to the uncertainty of whether it would slow the spread or not, and just invest our resources on providing individual risk reduction. What I used to call it focus protection, but now I like to call it state-supported individual risk reduction. If we put those measures in much earlier, January, as soon as we knew there was this virus abroad, we knew what the risk profile was already, we knew who was vulnerable, and if we had put those measures in, and which also includes, of course, infection control in hospital settings, setting up, making sure the care homes weren't being seeded, those are the measures that we should have put in, which were robust to the uncertainty of whether locking down would slow the spread, stop the spread, or do anything to
The only thing I'd come back, if I may, just from the clinical experience, was that we could not have kept anyone alive if the numbers had gone up.
We could have reduced the numbers by stopping those who were vulnerable from getting infected.
I can tell you right now, a lot of the people we had in weren't obviously vulnerable. I mean, 62%, of the British population are obese or overweight, which is a big risk factor. Age was, male sex was in the first wave. Comorbidities, which are highly prevalent, as you know, across Britain, were there. We had a vast range of people. It wasn't just elderly people with heart failure. It was 30-year-olds, it was 20-year-olds. It was the sort of demographic that we see normally in hospital with the same people that we get coming in because they're the people who have comorbidities. And there were lots and lots of them. And whilst you could say that people with the Denisovan DNA, as we later found, from Asian populations who were overweight, who were male, were at higher risk.
Yes, well, they shouldn't have been out there. They should have been told to stay at home and not drive our buses or clean our hospitals.
White 40-year-old bus drivers who were male.
Yes.
And plenty of those. And
it's nothing to do with black or white. It's being...
Well, no, it is to do with black and white, actually, because it was a big risk factor. And so, really. But if you took those, it wasn't the first wave, and we've done the genetics from Edinburgh. If you've taken, what I'm saying is, there are so many of those groups, for us to keep them out of the units, which would be great, you're still ending up in the first wave, what you're saying, slowing them down. If we had any more in, we had oxygen pipelines just breaking down.
But what did we slow down?
The numbers, if you get them in, what we're coming to, I suppose, is even, to take your point, is if you had the same number over a few weeks, it was manageable. If you'd have them on sport.
No, but what you're saying is we should have, you're also arguing for focus protection, you're just saying it would have been quite a wide net.
I mean, there's a question about who gets focus protection and when do you identify that they require it? Could we have known it before or not?
I mean, I think if I could just somehow broaden this a little, I mean, I think the clinical experience I completely accept. I think it clearly was an extremely intense time for anybody working in intensive care and anybody in the nursing profession who's trying to deal with a very difficult situation, a terrible situation. But I think that, it seems to me, there are two things going on here. What was the purpose of the lockdown? Was the purpose to buy a bit of time, to gain, to create better medical environments, more medical spaces, better equipment for staff, so that after 5 or 6 weeks, everybody was in a better place to deal with something which I'm not a scientist, but having studied closely, I tend to think, if you look at the overview of 2 years, and countries which locked down and countries which did not lock down had a pretty similar outcome. And, for example, a recent book by Francis Lee and Stephen Maceda shows that in the US, states which locked down, states which didn't lock down pre-vaccine have very similar outcomes. So the fact is that what is the purpose of the lockdown? Is it to slow the spread, or is it to create a better medical environment for treating people who are going to get sick? I would say it's the latter. And I would say also that we can actually learn from other countries. So Nicaragua, for instance, people may be surprised for me to talk about Nicaragua. What did Nicaragua do? Nicaragua, in January and February, had teams of medics going around all the houses. They made 5 million home visits in a country of 6 million in January and February. Between 2010 and 2020, Nicaragua, which I say had a population of 6 million, had built 20 hospitals, and they did not lock down, and they managed to treat the people in those hospitals because they did not work on a just-in-time basis, which is what has happened to the NHS. It works on a just-in-time basis, which does not work in a medical emergency, and one of the lessons we have to learn is that that is no good for treating emergencies. So we have to think about what the purpose of the lockdown is, and we have to stop thinking that we react to an emergency, we prepare for an emergency now, when it comes 10 years down the line.
And I would agree, actually, with everything you just said, but to answer your question, I think in that first wave it was, firstly, to stop us getting absolutely overwhelmed, which we still were, and it was, I agree with all of people, we weren't proactive enough early enough. And the second was to buy us that time to try to work out. Because I can tell you, I was running the international calls from the first Monday with China, Italy, Iran, anybody and everybody that had them or might get them, and we genuinely didn't know. They could not give us the data about who was at risk. ICNARC was producing the data on a daily basis, and it was only from that we were starting to see in Britain who was at risk and who wasn't. But the data from China, that we couldn't get solid data from them, and we were speaking to their CDRC, and the patterns there were very different, I think.
I didn't have that impression.
Sorry, what was the original question?
How this is going for us. I mean, well, the question was about what measures were taken and the sort of separation between what measures were taken initially versus what measures were taken later on. So right now we talked a lot about, the first lockdown, the perhaps choices that were made or the assumptions that we brought in that led to the first sort of PPE decisions in hospitals. But, for example, vaccine passports. That was a decision that got brought in, a sort of measure to help us control the spread of this virus. That was one of the later measures, one might say. So I think what I'd like for us to talk about now is sort of, let's think about a bit of these less sort of immediate and pressing first wave measures, more what happened as we started to learn more about the disease. And importantly, I'd like for somebody to also comment on our metrics of how did they work. Right? Because we're talking about statistics a lot, right? Like, how do we measure or decide, has this approach worked, yes or no?
Well, I mean, just first of all, I mean, what I understand about the first lockdown is there were predictions at the time that perhaps many more people were infected than we thought. But actually, by the time we got to September, studies showed that only 7% of the British population had been infected with COVID.
That's not correct.
Well, look, we can debate papers, your papers, but these are very well sourced papers, and many epidemiologists have quoted that. So I'm just going to leave that on the table. So I think we certainly did slow the spread of the virus. Obviously, what we completely got wrong was the idea that there was such a thing, you could achieve herd immunity with COVID. We're still seeing constant COVID infections.
That is categorically incorrect. You can achieve herd immunity. This is where we are at now.
I thought you didn't think that. I thought you thought we couldn't achieve herd immunity.
Why would you say that? And that's what I teach my second
Well, we haven't
students.
achieved it yet.
Yes, we
For
have.
COVID, I think.
Of course we have achieved herd immunity.
No, people are still getting COVID.
That is not the definition of herd immunity.
Okay, all right. Can we not get too stuck in, because otherwise we're going to be sort of
We
going
have
back
to
and forth.
be clear on our terms.
Right.
I mean, we can't. I agree. We shouldn't argue over niceties, but herd immunity.
You just said you began this whole debate by saying we couldn't stop COVID. That was a mistake. The way we thought we could stop it was with herd immunity or vaccines.
No, that's not the.
That was the argument made at the time.
Yes, well, that wasn't a correct.
And that was erroneous. Anyway, can we move on? I mean,
Yes, I think there were some fundamental misconceptions floating
so
around.
you've had a good go. Can I finish my piece? The other terrible error was this thing about it being a droplet infection. There was so much evidence from medical history on how light pathogens like tuberculosis spread in closed settings. And if you want to know more about that, there's an excellent book by the New York Times science columnist called Carl Zimmer called Airborne, where he documents in great detail how we really should have known that this was, that the most infections occurred either in super spreading events, in restaurants or bars. The other place, and this is why I always have problems with the Great Barrington, is we know that something like 80% of infections occur in households, of the elderly I'm talking about, multi-generational households. And if we're concerned about the impact on the poor, this was the dilemma we faced.
So locking everybody in is actually going to protect people then, because surely they're actually, if somebody gets infected, they're all going to catch it, which is exactly what happens.
What I'm saying is this idea that you could focus protect. I can focus protect my 94-year-old mother who lives in a 3-story house in Notting Hill on her own. But if you're living in Tower Hamlets in a multi-generational family, and you've got the grandparents with the children, you're not going to be able to focus protect.
Well, nor are you going to be able to protect them if economically you force them to go out and drive taxis where they get infected and they bring it back and everybody is stuck at home. So there's no
the
chance.
alternative, they just stay at home anyway.
No, there is another alternative.
Hold on. We definitely want to have disagreements and a conversation here, but also we need to be able to hear each other. So, there is a question which we are parking regarding the question of how things are measured. And as a scientist, I personally find that quite interesting. I appreciate that perhaps is not something that everybody else in the room wants to niggle on. So we're going to leave that. Now, this question about the sort of locking down the generational housing. Toby, you were saying that people were required to go out and work.
Yeah, I mean, I heard many stories actually of people from East London. In fact, as soon as you mentioned it, Mark, who the measures which were brought in, furlough. Let's think about furlough. Furlough costs a vast amount of money, but if you were on a minimum wage, it was actually only giving you 80% of your salary, and not only that, but of course your costs were going up because people were at home. Energy bills and so on. So, it wasn't enough money. So people were, having to go out, they were. That's the reality. That's the economic reality, And there was a massive socioeconomic dimension. It was effectively a class-based policy. And those, who had jobs where they could stay at home and worked well, that was fine for them. But, that isn't the majority of the population.
So I'm kind of curious, actually. I mean, feel free to clap if you want to clap. Yep. I'm kind of struck because actually, I'd like a bit of a historical perspective on this. Okay. Furlough, as a concept, did that exist before this pandemic? You'll forgive my ignorance. As a strategy for solving public...
Well, for a very simple reason that lockdowns and social distancing had never been applied in a pandemic. You can't find it mentioned in a single pandemic plan prior to 2020. This is the most extraordinary thing. I mean, nobody foresaw that, what were the first things we saw that alerted, as a medical historian, long before we had any data or hard information out of China, the image that struck me was those images of the Chinese overnight building these massive hospitals, laying the ground for new hospitals, and building these massive waiting rooms full of bunks where they were expecting to be full of severely ill patients. And when I saw that picture, I immediately flashed on this iconic photograph of the 1918 influenza pandemic, which was taken at an emergency influenza ward in a gymnasium of a US Army training camp in Kansas, Camp Funston. And what you saw there, this has been seen as the herald wave of the Spanish influenza. And the picture shows all these cots in this vast hangar full of recovering influenza patients, men who've been struck down by what they call a 3-day fever. And when I saw that, I thought, this looks and smells very like that, but without knowing any of the details. But the other thing I found extraordinary was, when China locked down, I said, that could never happen here. We could never do that here. And it comes back to my initial point I made. It was a failure of imagination. And it comes essentially to this question that we've been sort of circling around, is we don't have a grown-up conversation about death in this country.
Yeah,
recently we've had this fascinating debate about assisted dying. And the thing that, one of the things that makes me most angry, and I don't know if you agree with this, is that I know that there were discussions very early on in the SAGE and the subcommittees around should the government draw up formal guidelines for triaging ventilators and access to wards. And then in the end, I understand they ducked the issue and said, no, we'll let the clinicians will make that decision at the bedside. And I thought that was terribly unfair on the medical profession.
So let's do it. So it sounds like you're suggesting that the government sort of absolved themselves of their... Well, first of all, we're saying we were inspired by China to come up with this idea of a lockdown.
Well, I think it wasn't until we saw that people actually thought that lockdown could be a possibility,
Right,
you could achieve it.
But then we didn't want to deal with the death thing, so we said, you know what, we'll leave it to the clinicians. How did that go down?
Well, actually, oddly enough, I speak for myself here because I don't think it's fair that I should try and represent a corpus. I don't think it went down as badly because that's what we do for a living. I mean, that's my job most of the time. For clarity, I'm not aware of a single case ever in Britain, and I've got pretty good tendrils out, where someone was denied treatment for lack of resource. We were worried we were going to get pretty bloody stretched. But if people weren't put in intensive care, it was largely because we felt that they wouldn't benefit from it, which is the reason that we would always apply. I mean, it was going to make 2 points actually. One on the communications piece, because oddly enough, we really, really do want to have this conversation about death and about what is acceptable. And we actually had a TV crew. We were doing a documentary about intensive care. It was about to start. Our people needed to open that conversation publicly. Just say, we don't know what's right, what's wrong. We just want to have a conversation. And then COVID hit. So we ended up having the whole thing derailed, and it never happened. So that conversation is still needed. The second thing I was just going to mention was, because you commented on wave 2 and wave 1. Wave 2 was very different, not just because of societal factors and spread. It was different because three things really, apart from the societal bit. Number one, the virus had mutated and was different, and it was behaving differently. It really was. It was not the same sort of disease on ITU in wave 2 as it was in wave 1. Secondly, we had vaccination, which had really made a huge difference. And thirdly, and it is a societal thing to talk about, which plays to your point about disinformation, state actors around the world had seized that opportunity to seed disinformation. And a very large number of the patients we saw admitted in wave 2 had not had the vaccine. And they'd not had the vaccine because they'd been convinced by social media campaigns that it was injecting with 5G or any number of other features. So it was a very different demographic in the second wave in terms of why people...
So I really want to...
I'll just say one thing.
It's still 400
I mean, I think this is all very... I'm really pleased we're having the conversation around death, because I think that that's vital. But I think we also have to confront the reality that the policies that we chose, our desire to stop the spread, caused enormous harm to people in care homes. The idea of shutting people away from their loved ones in the life expectancy for somebody entering a care home is 1 year. Anybody who goes to visit a care home, as I have recently to see my uncle, will know that it is utterly cruel to deny people of the right to see their family for any It's one of the most cruel and inhumane things that anybody can do. And the reason that it happened was because we have not had this conversation about death, so I think that is really important. I'm glad we're having it. And that should never, ever happen again in any country, as far as I'm concerned. I think it's utterly shameful that it happened in this country. I think, and lots of countries. I think, but I want to come back to what Mark made. You said, as soon as you saw what was happening in China, you thought, this reminds you of Spanish flu. But then in the first edition of your book on the pandemic century, you wrote, the last page is about the WHO and swine flu, and WHO's declaration sparked widespread panic. The anticipated viral Armageddon never materialised. Instead, WHO was accused of faking the pandemic for the benefit of vaccine manufacturers and other special interests. So how are we to know that things were different this time around?
No. I mean, during swine flu, we didn't see any countries in Southeast Asia building new hospitals overnight in the expectation of volumes of patients.
No, but I'm just quoting your own view from your book.
No, that was a view on swine flu. That's a completely different pathogen.
I'd like to say a few things about... No, I'd like to say something from the point of view of imagination, which is not something to do with epidemiology. Okay, so what... maybe it was unimaginable that we might lock down for obvious reasons, but what was not something
unimaginable? We didn't imagine it.
You didn't imagine it. But what we didn't need to imagine, you don't need any imagination to know exactly what lockdowns would do to people. That did not actually require imagination. You know exactly what will happen to a 4-year-old child stuck in a tower block who only gets there one hot meal a day and switch. And that requires imagination. So what we did is we took something that we knew would happen, and instead of basing our policies around a precautionary policy around something we knew would happen, we decided to go for a policy based on something we imagined might slow the spread, stop the spread, and actually the reason why I said spread is in non-vulnerable people is valuable is because it leads you to a position of herd immunity in which you reach an endemic equilibrium, you reach an accommodation with the disease. So we tried all this, and I think what happened is, I agree that in the first wave the options were limited. I think it's not that productive to sort of have a huge argument about what we should have done in the first wave. I understand why, because there was a sort of consistency of narrative around that. But what happened by the time we got to the second wave is that because there were no debates, I'm not saying I was right, I do think that the epidemiological models would suggest that there had been considerable spread in some parts of the United Kingdom, and coupled with seasonality, that would explain why things were the patterns that we saw, rather than any non-pharmaceutical interventions. But because we didn't have this proper debate, I think what happened subsequently was what I call narrative collapse. So instead of having a consistent argument, whether it's right or wrong, to say, stay at home, this will stop the spread, these are consistent narrative, features. But what we got then was narrative collapses. Okay, no, wear a mask, but you can take it down if you're having a Scotch egg, or, you can stay. There was a complete because we went from narrative to an establishment of a doxa, what happened was that fractured, and then you got narrative collapse.
Hugh,
No, I certainly agree with that. I do. I mean, you know, there was sort of an insistence on certain things being true, which were very controversial, and we later learned were not true. So yeah, that was a very dangerous. I mean, the broader point I'd like to make is that although, you know, nobody had conceived of lockdowns before, and you can't find social distancing, of course, throughout history, and I think this is the main failure. What I learned from the pandemic is, you know, my book was looking at 100 years, a century of pandemics, but really, I should have been looking along much longer time frames.
Yeah.
Because if you go back to the Black Death, you know, plague, the cholera epidemics, there are plenty of examples in history of communities, people spontaneously changing their behaviour when faced with an uncertain risk, an uncertain disease risk. And I think that what we got right, what I was trying to say, is that people could understand if you made a reasonable argument that seems like protect the NHS, save lives. And I think people could have been persuaded to change their behaviour voluntarily. Yes, maybe the majority of elderly people could have been persuaded not to go out and mix and stay at home. And maybe young people could have been persuaded not to spend so much time in crowded restaurants without actually compelling people to do this. Because that's how people responded throughout history. You know, Europe used to have a string of quarantine stations all along the Austro-Hungarian Empire. Because, you know, there are tried and tested practices of, you know, isolating people to make sure they're infection free. So there were all sorts of things we could have done, tools that have been used in history. And also we could have, you know, I think another fundamental error was, do you remember very early on, people saying, Chris Whitty saying that, you know, if we go too early on the lockdowns, people get behavioural fatigue. You know, I think what I saw certainly in that period is even before we locked down, people changing their behaviour, the streets emptying spontaneously.
I mean, I always think that we need a psychologist in the room for these sorts of discussions. Hugh, you've been waiting patiently. What would you like to?
I was just, again, I'm trying to not project my own personal views too much onto this because they are my own individual ones and I don't want to represent others. But what we're hearing this evening is there is a plurality of thought, and that was represented as well across the population.
Yeah.
So if you think there are still people in the COVID inquiry who at the time that are spitting tacks that Matt Hancock let COVID out into nursing homes, that it killed their elderly parents, it was an abomination that these people the vulnerable should be exposed and die. That is a view. There is another view to say it's an abomination to stop people visiting elderly, demented people, for instance. Yeah. That is another view. And then we've got this protect and isolate, which also mixes into those sorts of things. So whichever policy was enacted, imagine I was a Prime Minister, heaven forbid, I'll get torn to shreds whichever way I jump on that one, because there will be a group of people...
And it's because we have not had the conversation about death.
And to pick up on your point, which I think is exceedingly well made, because we have very unrealistic expectations about what medicine can do, actually, very often. If you're going to admit into a nursing home, there's 1 in 200 are dead within a week of arriving. You've got half of people are dead within 3 years. You've lost a third of them within 1.5 years. And if you're demented in Britain, your median life expectancy is around 5 years, just with dementia. If you've got advanced dementia, it's very much shorter. And if you're elderly advanced dementia and you get bad flu, let's say, it's going to finish you off. And we don't seem to accept that this might be the natural order of things.
I mean, my wife's grandmother apparently called pneumonia the old man's friend.
My father did the same.
Yeah.
I mean, it has to also be said that, of course, there's death, right? And what we do or don't do in the face of death. There's also a matter of sickness, which is actually what we're talking about. And why do older people end up in these old people homes? There's a question of the sort of unsightliness and ugliness of sickness and the discomfort that people get from seeing it, but also there's a question of the labour, right? Because somebody has to take care of people who are sick. And a question of, do we wish to do that work? Do we not wish to do that work? I want to do background to something that was sort of, I mean, in the death conversation, actually, I think this is very critical, actually, because what we do is, as a society, I think it's fair to say, we kind of leave that decision to the doctors, don't we? Sort of a little bit. But I would argue almost there's an argument to be made for before sort of professional medicine existing, deaths just sort of happened to you, or it was more of a social thing. I mean, what are your thoughts on this idea of how sickness within broader societies is managed, and the role of medicine and medical professionals to sort of absolving us of those responsibilities?
Well, one of the points I was going to make is indeed that, you know, there's death and there's sickness, and there obviously it's the same discussion really, what does one expect of life, and ease and dis-ease, etc. I think we've talked about this before. And so obviously there are certain expectations that are embedded in certain societies, affluent societies, should we call them, about how life should be lived, and how much risk we should be taking with regard to being ill. And I think that's something that we haven't talked about. We do talk about avoiding deaths, and that's certainly something we want to do. But the other aspect was that a lot of people were going to get ill. A lot of people were going to get sequelae like long COVID. This was going to happen, and we need to have a mindset and the resources to manage that. So this hospital in Kansas, it was actually a fever hospital, was it not?
No, it was an army camp. It was a barracks. They converted a gymnasium into temporary.
Yes, but what, you know, why did we not make a provision straight away for fever camps where people who were going to get ill, need some support? Now, I don't know, you will know whether that's possible. So partly, first of all, so that we had a system whereby people come in, spend a couple of days, get some oxygen if they needed or whatever it is, and then, but also in order to provide infection control, to keep them apart from other vulnerable patients.
Some really good points, and I can address some of them. And again, it goes back, I think, partly to start with the fog of war. So first, we didn't know that this was a virus that would insert itself into organs in the way that it did, because quite a long time I advised the judiciary on long COVID, and we didn't know at the start that was going to happen. The infection, of course, the problem with it, and the variants all differed, was the infectivity long before you had symptoms, and that was a real problem, because people weren't, and obviously when they felt lousy, were coughing all over everybody. But a lot of people, as you know as well, were asymptomatic. They didn't even know they had it, and were spreading it around, and that made the isolation difficult. And in hospital...
Not so much, I was just thinking of case management once you...
Yeah, and once you've got it, most people, most people in this audience probably had COVID, and they managed quite well with a bit of paracetamol and brufen.
Of course, but there were going to be, because it was an epidemic, there was going to be a rise in, non-severe cases.
Yeah, and
we needed to have some system in place to manage that.
Yes, and it's difficult, though, to know what you do with them. So I could...
Well, you have to keep them away from vulnerable cancer patients, is the first thing.
Well, you do, but those people tend to keep themselves away anyway. I mean, when they're at home. But in a hospital,
no, but if they come in for some treatment...
But there isn't a treatment, that's the issue. We didn't have any treatments at all to give them to start with. Oxygen doesn't on its own save lives, strangely. You need a step up from that. And that was where the kit and the oxygen supplies ran into trouble. For clarity, it wasn't an issue that we couldn't make enough oxygen. The problem was the manifold systems built into hospitals are designed, if you lower the pressure, to think there's a leak and that something is going to explode and switch themselves off. And you can't really bypass that. And globally, that was an issue. So I think the bit I'd come back to as well, which I think your point's well made, is the disease and health bit. And that is something I do get very exercised about, is that we have abandoned public health to some degree in Great Britain. And if you look at one of the reasons, perhaps when we had quite so many more severe cases, it was partly due to this huge burden of obesity and overweight, where it's north of 62% nationally. It's 3.7% in Japan. And in Finland, it's 14%, because they've legislated about public health matters. And we don't seem to have learned that lesson at all. And that's not a party political point, it's a generic point.
So I'm struck by how many times you've all disagreed with each other, but how sometimes you all seem to agree with each other. And so as we have a few moments now to cast our collective eyes on the panel towards the future and future actions and what we would like to take from this before we go to the audience for questions. I am struck by the word imagination here. I have to thank you, Sunetra, for bringing that to the table, because actually, if I may make a humanist point here, I think what makes us special is that we can imagine things as human beings. And so this is actually quite an important moment for us to collectively think about, maybe reflect a little bit on what led us to imagining the solutions that we came up with, but actually to imagine what we're going to do going forward. So Hugh, you said more sort of public health measures. Mark, what would you encourage people to think about, or future measures?
Well, we can go through a list of very specific recommendations that will all be coming out of the COVID inquiry. I mean, top of the list, I think the thing I never got a chance to say is the thing we got so wrong were the prolonged school closures. And that was just appalling, and we're seeing the impact still today. But knowing everything we know about COVID and the importance of ventilation, we're still not investing in proper ventilation and renewing, the fabric of schools. So we could talk about a whole list of things that we could do very specifically. Obviously, more ventilators, more capacity. None of this working at, right up to capacity. I think the fundamental question comes down to this ethical question. In biopolitics, it's this idea that we have a choice in modern societies. In a way, if you go back to 1918, there was no thought of being able to stop people dying of the Spanish influenza. Indeed, I spoke to, I didn't speak, there was a chap who did some research at the London Whitechapel Hospital, and he discovered that there were doctors practicing throughout the pandemic who weren't in the respiratory ward, who had no idea they were in the midst of a pandemic, because it was all happening on one ward. And where were all the other deaths occurring? They were occurring at home, invisibly, out of sight of the wider community of the media. And even in 1957, when there was an outbreak of Hong Kong flu, which killed, I think, in excess of 1 million people. Was it Hong Kong or French? It was the other one. 1 million people worldwide. The British government, there were cabinet minutes where they actually discussed what should we do, and they said, we're not going to do anything. We don't want to panic people. So a lot of the choices we're faced with are because of the medical progress we've made. There were no antibiotics in 1918, there were no mechanical ventilators, there were no vaccines. We have all these things today, but we're still faced with this choice: who do we allow to live? Who do we intervene to allow to live? And who do we allow to die?
That links beautifully to what you were saying, Toby.
Well, yes, about death, but I want to make a sort of broader point. I mean, the imagination of lockdown, but I think that, one of the things that we absolutely have to learn is that risk profiles are different in different countries. And what people can do is different in different countries. So, Mark, you say we hadn't imagined lockdown before, nor had we imagined. Well, in fact, that's not true, because as you also write in your book, there was a lockdown for Ebola in Liberia and Sierra Leone in 2014. And as you also write in your book, it was extremely unpopular. It provoked riots, and Ellen Sirleaf-Johnson had to, you said, I think the words you used was, she came to her senses. So the idea that we were going to impose lockdowns in the global south, a friend in Nigeria tells me that in Nigeria it was called a 3-day policy, because after 3 days you start starving. And in fact, it's had an unbelievably catastrophic effect in the global south. So the UNDP at the end of 2023 said that 50 million people in Africa have fallen into extreme poverty because of COVID. Now, this is a lie, because they've not fallen into poverty because of COVID. COVID deaths are very low in Africa. They've fallen into poverty, extreme poverty, because of the COVID measures, the shutdowns, the complete cessation of the service economy. It had a massive gendered effect. It was called a shadow pandemic by the UN. Huge increases in prostitution, 4.5 million children in Uganda alone cut out of education, huge increases in child marriage. I mean, the idea that a global solution which takes no account of socioeconomic differences to slow a spread of a disease which is affecting primarily, we all knew by May or June, in general, elderly people, was such a catastrophic mistake. So we have to learn to disaggregate risk, that what is possible for people in North Oxford or Chelsea is not possible for people in Lagos, Kinshasa, or Oldham, or Peckham. And those mistakes, if we don't learn them, and the failure to understand that, which is a very basic point, frankly, has led to huge distrust in government, huge increase in fragmentation, and a complete loss of hope and optimism as we see in society around us. And so we have to learn those lessons.
And your question was looking to the future. We haven't learned the lessons. I've made my short list there. The first is this, what you started with, the public discourse. We must start talking about these issues. And not everyone is going to be happy with the outcome, one side or the other, which is inevitable.
Yeah.
But we need to, as you say, be able to have open discourse and understand that there has to be a decision made by a government in one way or another in the future. I think we should be strengthening public health in Britain. I'm anxious that we're eroding it. I know that there's all sorts of economic pressures in the government at the moment, but I also recognise that if we dismantle our public health surveillance systems, we're going to be caught out worse next time. We've eroded potentially some of the vaccine manufacture in Great Britain, which was, I think all of us would agree, with an enormous strength. And we did get, I suppose we didn't, you did actually, I think both of you said the vaccine.
Yes, the vaccine
was a terrific thing. And I don't think we're in a stronger position. I think we're in a weaker position. We're certainly in a weaker position with clinical academics. I'm 63, and there are very few of us left. It's not because we've all snuffed it, but some have died, a lot are retiring, and there are very, very few coming behind. We haven't supported clinical academia in this country, and that really genuinely did help us. I think we're not paying attention to public health measures, and I am the turkey voting for Christmas here. In answer to your question about do we fix it by having more ventilators in kit, I would say no, we need some. But these systems weren't just lungs, it was brains, kidneys went down, blood clotting. It was incredibly complicated, which is why the bigger centres that were built just were never going to work, because they were basically built for you stick a tube down and blow some air in and out, and it's not like that.
But there weren't enough staff either.
Indeed. So the answer, I think, has to be that we go back to addressing public health in this country, because we know 800,000 people not working due to chronic ill health. Yeah. They can't contribute to the economy. They're a burden on the taxpayer more globally. The health service is under strain. And a huge amount of what we see in hospitals is entirely preventable from public health measures. But no one will bite the bullet because they're actually anxious about the nanny state argument. And that's something else we need to discuss.
I think that ties very neatly to something that Sunetra was saying about the issues of ease and dis-ease. Actually, I think a lot of the public health issues that you're flagging come down to the fact that we live in a world of personal choice, but who would choose to intermittently fast and live in a cold environment and lose the weight and be careful about the caffeine and be careful about the alcohol and all of these kinds of things. Sunetra, what are your thoughts about what we need to be, what other kind of conversations do we need to be having going forward?
Well, I mean, obviously the strengthening of public investment in infrastructure, anticipating and having some sort of fat there, some sort of leeway. I mean, not running it lean, because what we're doing by running it lean is we're asking the children to pay, the next generation to pay for it, because when there is a disaster like this, then we say, okay, let's shut everything down, and the people that impacts are the younger generation and those who are economically disadvantaged. None of this is going to happen unless we do something about the are issues with inequality right now. It's just not going to happen. And that is, of course, I think contributes to both of these issues, the fact that we're not building, don't have the right infrastructure, and the sort of individualism that you're talking about that underpins this notion of dis-ease being a state that is absolutely unsupportable. I think so the growth of individualism, I think, is really one of our biggest problems. And I think that lockdowns were a manifestation of that. I know it was dressed in the other way, that it was supposed to be all of us doing something together. But frankly, it was really the laptop classes throwing the working classes under the bus. And yet it was the level of virtue signalling around it, I thought was very problematic. That's, of course, my viewpoint, but because I don't think anyone benefited from lockdowns other than the laptop classes, and because the damage was so extreme, I don't think it did anything to stop the spread of the virus. But even if it had done, I think our choice, we had a better choice, which was to protect the vulnerable. It's not always easy. We can talk about how you might achieve it in the multi-generation families. But it is, I think, overall, the better choice. And that essentially is a communitarian. It's a return to communitarianism. It requires a little bit of sacrifice. I mean, I was told that I couldn't go and teach my undergraduates because, aged 55 as I was then, I had a slight risk of dying of COVID. I'm happy to take that risk. Why shouldn't I? I walk out the door and I take the risk of getting a car to teach my...
Yes. So, I mean, as always with these things, there's never enough time. So I'm going to sort of say, I think we're all in agreement that public health measures and the importance of public health was very much proven during this time. I think that we've all flagged, actually, in different ways, that conversations around difficult subjects is something that we really need to do going forward, whether that's about death, whether that's about sickness, whether that's actually the uncomfortable conversation about inequality and about the fact that we can't make everyone be the same, and how do we actually bridge those kinds of differences, whether it's within our own country in terms of, North London, South London, Chelsea, not Chelsea, or even within the country, or even between different countries. There's a lot of discomfort around the recognition that we are different from each other, but also something quite important about the fact that this experience did actually show us that we are still part of a whole. And I feel like what I heard from what you were saying there, Sunetra, is, sometimes taking a very focused view on something like, let's just reduce the number of people who have COVID. In focusing on a single parameter, you lose sight of the bigger picture, which is, what about children? What about working people? What about all these other dimensions? And that sort of slightly more holistic approach is something that I think is difficult to talk about, and I would class that as another one of those difficult conversations to have. So, with that, we have a bit of time for questions from the floor. Please raise your hands. We have 2 microphones. Fantastic. Please keep your questions nice and quick, if possible. I know it's a difficult ask. If you can direct it to a particular person, feel free to do so. If you just have a question you want to ask to the whole panel, just ask them.
Can I just say, I've been asked by our cameraman to say, can you hold the microphone to your chin, like this?
When you do that, fantastic. All right, lovely. This gentleman here.
Is that correctly to my chin? I think so. Right. Good evening, panel. Thank you very much. I notice that obviously time is a constraint, and there's been lots of discussion about the medical pros and cons and discussion of death and so on, which is valuable, but we haven't at all touched on the trade-offs. Now, 5 years on, I'll tell you, my starting position is lockdown was an absolute catastrophe with no redeeming features whatsoever. Sunetra, Sunetra, I thank you because you were one of the few people who kept me sane after I saw through the madness within 2 weeks. Anyway, now, what I wanted to ask the panel is this. The media coverage, I want to ask your view on the media coverage because, to my mind, we're supposed to have a free press in this country, but there was almost no questioning, no criticism, no interrogation of these appalling measures. I well remember a headline on the BBC News website in 2021 where they said, how to put on your mask properly. That is not news, it's state propaganda. So how on earth was the media coverage of this acceptable? It didn't balance it at all.
Okay, that was a comment rather than a question. Anybody?
I mean, I think it's interesting. Mark writes for the media, and it'd be interesting to have a different perspective. But elites have always sought to control information. That is what political elites do. We shouldn't be surprised that this would manifest itself in different forms and different frameworks, and this is the way in which it manifests itself here. And the fundamental problem with that control was that it created distrust, and that's what we see. So I think that it was a manifestation of elites' attempt to control information, which political elites always do. That's what I'd say about it.
Can I say just very, very quickly, I think you're mainly making a point when you say the media, you seem to be talking about the BBC.
Well, mainstream media, most of it.
Well, so just to deal with the BBC first of all, I agree. I think they cleave far too much. They took their messaging directly from NHS England. And I remember this very clearly because before lockdown, I was going into various sort of radio stations, and I was invited onto Radio 5 with the BBC's health correspondent. And it was around the time that in Italy they'd closed the Premier League, the League of Premier, and we were talking about similar things. And in Italy, the rule was a 2-meter rule, and the BBC health was saying, well, we have to keep 2 meters apart. And I said, but how can we have people going to football matches? Have you ever been through a turnstile at a football ground? You can't keep 2 meters apart. But on your wider point about the media, I think there was plenty of debate. I mean, the Telegraph and Daily Mail were full of lockdown skeptics. And all the arguments were very well rehearsed. The criticisms of the lockdown were very well rehearsed in those pages. So I don't agree that it was a monolithic. Yes, with the BBC, I think that there wasn't enough questioning. So,
I mean, The Guardian actively took us on. They labelled us as right-wing conspiracy theorists.
Yes.
So it wasn't just about not letting us speak. I mean, the BBC did tell me, you can't mention this, you can't say that. And I remember a journalist saying to me, lockdowns work, everybody said so. Says so. To which I simply said, doesn't mean anything.
I think we've all flagged the importance of having conversations, and if there's one thing that I assume everybody learnt from the lockdowns is that messaging has to be kept up to date, and having a plurality of opinion is actually, surprisingly in a democracy, our strength.
I seem to be elite and in control of the information, so as I've got the microphone, I'll ask a very brief question. I'm Ronan Salmon, I'm a retired medical epidemiologist. I was on the advisory committee on dangerous pathogens. I helped with some of the drafting of the pandemic plan, so I'm morally bereft and lack an imagination. But the point here is the conventional way of measuring the effect of these pandemics is by looking at excess deaths, something that's been touched on. These have been looked at in detail in country comparisons through the pandemic. And the conclusion in the biggest study, which came from Italy, from 23 countries over the whole 3 years, was, although you could show associations as Hugh has indicated with gross domestic product, with inequality as measured by the Gini index, as healthcare expenditure as a percentage of GDP, as the success or failure of vaccination campaigns, these studies have, and I quote, failed to identify a significant relationship between the stringency of non-pharmaceutical interventions implemented by European countries and excess mortality. So my question is, in a sense, why are we having a debate about lockdown when clearly as a social policy it simply didn't work in the primary way of preventing excess death?
Does anybody want to comment on that?
well, I mean, I'll just a very brief comment. Would it have been better then just to let the pandemic spread?
We're not here to start a conversation.
Okay.
Why is that the only alternative?
I suppose the question about excess mortality is when those deaths occurred, right? If they would spread over several years, as opposed to preventing the immediate deaths of the
Well, one thing we didn't discuss, which I think is significant, is the measurement of death, and we did discuss, we might discuss that, but the fact is that whole countries changed the way they measured COVID deaths. Peru, for instance, doubled its COVID death tally overnight in the middle of 2021, so it has the highest death. Italy, by contrast, reduced its deaths to 4,000 because it didn't include comorbidities. And the fact is that excess deaths are the most reliable measure of mortality in a pandemic.
Okay. Sorry, Hugh, were you about to say something as well?
No, I was just going to say, I'll bring it back to the point we started at the beginning, and it is something that I don't know what's right. If we let it run without lockdown in wave one, there would have been, I can tell you, vast numbers of people dying then, vast numbers because I saw them dying, and they were not all elderly people at high risk, but that may be, I'm not arguing, that may not be, my own family was badly affected by lockdowns, and I'm just saying society has to weigh those two things up.
But why not just sure, I think what he's trying to say is that lockdowns didn't work.
Well, what they did, 20,000 more people would have died if we'd locked down, if we'd locked down a week earlier.
Okay.
20,000
Hang
more
on,
people.
I mean, that's an assertion, not a fact.
Hang on, order in the room, please. I'm in charge here. What we're going to do going forward is we're going to take a few questions apiece, and you're going to keep them short so that you can all ask your questions. Okay? We have a drinks reception afterwards so that we can continue these conversations. The speakers will be there, so you will get a chance to have those things. This lady here has waited very patiently. What is your question?
Thank you very much for your presentation. I'm a nurse and I was working at the Royal Free bit at the beginning of the COVID pandemic, and then I was transferred to the Nightingale Hospital, which was a temporary hospital in the exhibition centre. And I was just wondering, if we had it again, what should we do differently? Thank you.
Okay, thank you. And then this question?
Thank you very much. My name is Julio Alejandro. My question is about free markets. Most of the people within economics, they see, should we have more state intervention, meaning regulatory, forceful, obligatory measures that the entire population has to take, otherwise you go to prison or you can get into trouble against? Is there a role that individuals can take autonomously to make their own decision, the risk assessment, and would that have even better outcome? So is it more about free markets, individualism, or is it about, I don't know if you want to call it state coercion or the government forcing you to do certain things?
Okay, one
Thank
more
you.
question and then...
Yes, we all know that all Western nations are excessively in debt. And prior to the pandemic, let's say 2018, 2019, the IMF advised all these countries to get out of this by printing loads of money, creating inflation away the debt. Now, this may explain, and I'm asking the panel, do you think this explains the ridiculous expenditure of 390 billion, which was printed by the Bank of England on all sorts of policies, which the panel have generally suggested were a waste of time? And in respect of this, inflation since 2020 has been about 35%. So that certainly ticks the box in terms of reducing government debt. And of course, inflation hits the poor.
Well, I mean,
Question for Tony.
I agree with the point of your argument, but then you could go back and say, well, should we have, after the 2008 financial crash, introduce these extreme austerity measures, which resulted in widening inequality and a worsening public health infrastructure? And to this gentleman who talked about individual versus state, I think that's a very interesting question, because where we are now, post the pandemic, especially with extreme polarization we see on social media, the biggest challenge that we'd face when faced with a next potentially catastrophic pathogen or whatever the threat is persuading people to act in a way, to voluntarily change their behavior in such a way that would reduce the impact. What we absolutely can't do is present them with some monolithic scientific viewpoint. There never was one science that we could follow, okay? But as I keep on going back to it was never just about the science, it was about the ethical choices we make as a society, about what we fund and what sort of values we have. And I come back to 1918. In 1918, we did not have the possibility of saving lives that we can now save.
I have to say, Mark, I think the comparison to 1918 is really bizarre. As you also said, we had no antibiotics in 1918, and as you also wrote in your book, most of the deaths in 1918 Spanish flu came from sequelae which antibiotics might have been able to treat. So, the idea that, that somehow COVID-19 was another Spanish flu.
We have choices now because of advanced medical technology that we didn't have then. That's the point I'm making.
And with those choices comes
ethical questions.
An ethical and moral duty.
The question about inflation quickly, because it was kind of directed towards me. I think that this is a really extraordinary point, and we have to, I don't know, I have no opinion about whether a response to the IMF, personally I think it's unlikely. But I do think that we have to look at what happened realistically. Inflation hits the poor. That is a fundamental point. It exacerbated the class-directed nature of the policies, which has exacerbated the polarization. That's a very important point. And a second point is, the cost, as you say, £390 billion. Now, there was the amount of media coverage around, for example, Starmer's government's decision on winter fuel payments, which was going to save £1.5 billion. Versus the amount of media coverage of £390 billion when the National Audit Office itself, for example, COVID tests, we were told tests were a good thing. The National Audit Office estimate is that COVID tests reduced spread by between 2 and 5%. Okay, 2 and 5%. The cost was £37 billion. Now that is the entire national transport budget. It is the cost of building about 20 hospitals. So I think we have to be honest about some of this. And without having that discussion, let alone what's happened, for example, in Africa, which New International has described as entering structural adjustment 2.0. It's incredible.
Hugh, you've waited.
That's fine. I'll answer those questions very quickly as a non-expert. So firstly, thank you for what you did. I know what it was like. I'm sorry, because it is upsetting. And what I said earlier was not meant to be light. Nursing staff absolutely got it. The doctors were let off a bit more lightly than that, so thank you. Do differently. I stand by what I said earlier on. I don't know what the right answer is, but you would know what I know, is that we'd let it rip in that first phase, we would have had huge numbers of deaths earlier on because we were at max. The ones we saved was because we had just about enough with the skin of our teeth to get through. And if we'd had more than that, those people would have died. Now, I'm not going to make the argument one way or the other than to say we would just have to accept that or not. The second issue I would raise is the one on debt, which is a very long conversation for the bar, but it seems to me crazy that we attach value to debt, which then leads to a collapse in 2008, which we get over by minting more fake money, which then catches up with us, and then we do exactly the same to get ourselves out of harm. We don't think this is going to come back and bite the population, all of us, and particularly the poor. So I think the debt issue is very important. And the last one is one, again, on a free market view on health, which I think is worth making. The free market issues on most things in life don't affect other people very directly, but if you look at things like vaccination, it does. If you don't get your measles vaccine, that may be a personal choice for you, but it does have an impact on other people if disease is spread. Vaccination has been one of the most amazing things that happened since Pasteur and onwards. So that's one issue. There are others too on a more societal basis. We do regulate and legislate on things like tobacco and alcohol because they have societal harm which impacts others because, for instance, the cost we pay in our taxes to support those people when they get sick and the other harms that, for instance, alcohol causes to our society. I think it is right that we do. I'm not a believer in free markets for everything, is what I'm saying. I think we have to regulate and legislate for things that, for a common good, that's what societies are for. Where we draw that line is, I think, what we're talking about this evening, and I think that is difficult.
Just first of all, on that point, I completely agree that mandating, I mean, if what one has to do is get away from this idea that freedom and mandating things are actually in opposition. Regulated markets, I think, are the only way to actually achieve individual freedom. So these sort of binaries, I think, are actually not very useful. But just one point, this business of let it rip, if lockdowns don't work and we don't offer focused protection, we are effectively letting it rip. So it's not a binary of locking down or letting it rip. So I think the answer to the first question is, why are we talking about it when we do have a lot of data showing that lockdowns didn't work? Is because we want to know what should we have done otherwise. None of us wanted to let it rip, and at the same time, some of us were very concerned about the costs of lockdown, and now we know also that they didn't work very well. So really, what we ought to do now is just say, what should we have done different?
Protect medical staff. That's obviously a very important thing.
Protect the vulnerable right from the outset. Right from the
change the idea of the definition of the purpose of the lockdown. The purpose of the lockdown is not to get a better outcome, because it didn't do that. The purpose of the lockdown is initially to protect staff, get into a stage where they can treat patients and then manage.
I wanted to very quickly want an outbreak of common consensus here. I think I picked up on your point earlier on about socioeconomics as drivers of ill health, which we would completely agree on. And protecting the vulnerable, one of the problems we faced was that a huge proportion of our population were vulnerable because we've allowed, by market regulation failure, a large number of the population to become ill. And the way we get out of that, is, as I'm sure you would agree, is you can't punish people by saying, for instance, you're fat and it's your fault because it's a societal issue relating
but
to...
you could say you're fat. You're fat, so you have to stay at home.
Yes. No, but
we're going to give you the money to do that. I mean, that's what we should
do. But the point I'm getting at, I think, is that I wouldn't start from here, to quote the Irish proverb. If we address...
Okay, can we have some more questions? Because, we have lots more. Thank you.
We can...
Hello, my question is about whether people in positions of power and in ivory towers are too wedded to models and have lost sight of reality. And I would illustrate that by saying something quite simple, really, which is that since 2020 and 2021, there have been recurrent waves of this virus, and these waves have risen and peaked with about the same steepness of the rise and the same timing to the peak ever since. The timing of these peaks is predictable in terms of seasonality, and so it's like saying Monday and Tuesday, the sun set because of what we did, and every other day of the week it's set because of nature. And so, if you really are that detached from reality, if you're talking about it letting rip, it's nothing to do with letting rip. It's viruses come and go in that manner. The pattern is very predictable and repeatable. And just a last remark, that COVID patients did not get antibiotics. That's why we had a high mortality rate.
My question is about the origin of the virus. Even after 5 years of the pandemic, we have no clarity how the virus originated, despite several attempts of WHO and other agencies. Of course, we know that it happened because the Chinese government blocked those attempts. But do you think we failed as a global community to create enough pressure on China to allow the inquiry? And what impact it will have on the response to future pandemics? Quickly about messaging, since we spoke about it. In the early phase of the pandemic, in the first wave, experts were clear it's an airborne virus and they were talking about it. But WHO remained in denialism about it for a long time. And when finally it declared that it is airborne virus, people became skeptical. So what about the messaging? I'm not asking about WHO, but what about the messaging that we had here?
And the question behind.
Thank you. I'm a sociologist. My question's about the public. And what did it do to public trust that we stopped trusting the public during the pandemic? Before the lockdown happened, everyone was terrified, right? No one was going out. And after the lockdown, when the lockdowns were lifted, no one wanted to go back to work. Or that's an exaggeration. There's a huge problem there. That's still ongoing. And I think that's been, if anything, more damaging to the social fabric than the pandemic itself. So how do we get a more sensible reading of, what the social and cultural dynamics are at play that can be worked with in emergencies like this in the future?
Thank you so much. I have one more question.
Thank you. Well, it seems there is a consensus on the panel, first about the fact that we do need a solid public health policy, and also that we need to have a conversation about death. It happens that I do work with undergraduates who, most of them have been deprived of pretty much something like 4 years of their social life. They're struggling not just with anxiety and social behavior issues, but with social media addiction, porn addiction, all the bad things that can happen when you've been told to stay locked up in your room. And now they're being told, when they hear about the public debate going on about assisted suicide, that it's okay to euthanize Granny, while they have been told that they had to stay home to save Granny. Is there any way that, from the perspective of the experts, we could have some information that could lead to a less drastically pessimistic view on life? Because now the impression they have is that their life is only worth living if they can pay their taxes, live a decent expected life, but they don't even have enough money to afford housing, etc. So how do we give some hope to this generation that has been educated into believing that life is not worth it? Thank you.
So we are actually now officially over time. So I'm going to ask, thank you all for your questions. I'm going to ask every one of the panelists to give us just 2 minutes ideally on their closing remarks, ideally addressing some of these questions. I understand there are many of you in this room who had questions that you were not able to ask. We will be stepping outside for a glass of wine where you will hopefully be able to ask your questions and continue this conversation. So, why not, for the sake of continuity, why don't we go in the same order that we spoke in first? Sunetra, what are your sort of closing thoughts and addressing of questions?
I suppose the themes that emerge here are, once again, really the establishment of a communitarian approach to all of these problems, which was abandoned. And it's true that the fabric of society is very complex. And so to disrupt it, I mean, we've talked about the sort of bigger effects. We know that measures that we took plunged people into poverty, killed people, took away their livelihoods, etc., etc., that there's some very obvious measurable impacts on public health, mental health, and public health, of course, huge backlogs in the NHS, all of these things. But actually, it's worse than that. The tapestry was disrupted. We disrupted something that is very precious, that's very fine and delicate. And yes, we took away hope as well. So those are things that are considerations that operate outside of course, professionally what we've been talking about, which has to do with, should we do lockdown, stop the spread? Should we try and somehow insulate the vulnerable? What is the, so there are lots of practical considerations. But I always say that we need, I use sometimes sort of Aristotelian sort of rhetorical triangle with ethos, logos, and pathos as three aspects that we really need to actually consider. So it's not enough, I agree, to just think of the logos, not by which I would say, how did the virus, where did it come from? I don't think it came from a lab, but we cannot argue about that. But those are sort of questions of logos. But really, there is the pathos which we have talked about, the what happens to people, what happens to our lives, what happens to us, the socioeconomic consequences but there's also the ethos. How do we want to live our lives? And they are not simple questions of, I want to be free, I don't want someone to tell me what to do. It's about the whole fabric, the whole sort of tissue of life. And we need to be aware of how these measures affect that as well.
Thank you so much.
You know, I'm a historian, I'm not an epidemiologist, I'm not an expert on, you know, what measures would work best. And I think I think scientists should also be more honest about that. I mean, somebody raised a question about why were we reifying these epidemiological models? And that's a good question, but you could ask the same thing. You know, there was this endless debate about face masks, you know. And, you know, if you hold a randomized controlled trial as the only evidence you're prepared to admit and throw out all the mechanistic evidence, you know, the other sciences. So, I mean, at the beginning of this pandemic, you know, I rather idealistically hoped that, you know, COVID would be a moment where societies could actually come together and, you know, fight communally to sort of, you know, work in everyone's best interest. And there are plenty of examples in medical history where, you know, pandemics have forged greater social solidarity. But at the same time, you can also show many examples of where they've sown divisions and, yes, conspiracy theories. Every pandemic in history has been associated with a conspiracy theory. So I think the first thing we have to say is we're always going to be faced with uncertain knowledge. And, you know, science, there are many different kinds of sciences. We have to listen to as many of these as possible. And I would include not only the life sciences, but sociologists, behavioral psychologists, anthropologists, and indeed historians. You know, how have people responded in the deep past when we didn't have, you know, the possibility of furlough and quantitative easing? We didn't have the possibility of vaccines. We didn't have all these other marvelous medical interventions. And I think we have to trust people. This is what I take away. The reason I started by saying the one thing we got right was the messaging around the NHS, is because the NHS is a kind of secular religion in this country. And I think it's the one thing that forges national unity. Perhaps the only other thing is Remembrance Day. And I think we have to trust people more. And we are going to be faced with a huge problem, because that's clear in this room. Many people's experience of lockdown was depressing, if not catastrophic. So it's going to be very, very hard for any sort of top-down state messaging saying, you must do this, or I implore you to do X, Y, and Z. We're going to have to be honest about what we know and what we don't know, and we're going to have a grown-up conversation about what values and ethical choices we think should be made.
So 3 points, I suppose. The first is we didn't know what this disease was. I can tell you that because I was there and I'd had national roles as well. We didn't know what it was going to do to our patients. And we didn't at the time know when it first hit us who was vulnerable. And we were ill prepared because we were prepared, as you mentioned earlier on, for the wrong type of disease. We're not going to know again. When this happens again, it's unlikely to be a replay of an identical virus. And there are things that give me vague nightmares before. If we get a crossover or spillover event that causes, let's say, an encephalitis, that's a different beast altogether. If your brain is getting fried and not your lungs, for instance, and we wouldn't, if that hit tomorrow, I wouldn't be knowing what to do. So the first thing, there is uncertainty, and it's going to make it difficult next time round as well. The second is, I would again thank the organisers and all of you for coming, and my fellow panellists, because we've got to learn to converse. We've got to learn to have difficult conversations, share thoughts, as we've all done tonight, disagree, change our views, and I've changed some of mine this evening as well. But we've got to do that, and it's an active process that requires investment. And we must fight divisiveness across every part of the political spectrum, because it is not the way forward. I'm not advocating just consensus, but I am advocating conversation. And the final thing is, to use your analogy of the fields, we should not fertilise the field to get the weeds to grow in it in the first place, and that brings us back to public health policy. We should watch our fields and be careful to spot the weeds growing, and by dismantling public health surveillance globally, that's dangerous. And the third thing is we should retain, and you were talking about not cutting down to the fat, retain a capacity, even if it's not needed, to be able to make a weed killer quickly and deploy it. And we're failing currently globally on all of those three counts, in my view.
Thank you. Yeah, I'll try and be quite brief. I mean, I think most of the last comments from the audience were so powerful that they don't really require much comment from the panel. I mean, I think particularly around the young, you know, I mean, it was a medical emergency. It caused a huge amount of suffering to those working in both those who suffered from the disease and those who were treating it. It was a very stressful environment. But it's clearly also somehow acted as a rupture in human and social relations. Online has taken over to such an extent, even though we knew before COVID, there were lots of discussions around the impact of screen time on the young at that time. And what we did was, as you said, put them in front of a screen, tell them that was life, and we're seeing the consequences in massive gender-based violence in our society, in massive depression and all kinds of social consequences. So we have to recognise, we have to be honest about that this was a rupture. We may still think that some people will think that it was still the right thing to do, and that's fine, but we have to be honest. I think we also have to listen. I think, you know, especially in the world of social media, there's a lot of saying what you think. And I'm sure we've all been guilty of that. But at the same time, we have to start listening better, and particularly to young people, we have to start listening to them. And we have to have more of these conversations. I really hope that this is not the end of the conversation, but we will have more of them, and we will work together, those on the panel, to try and facilitate that, because it's absolutely vital, as you said, Hugh. You know, this fragmentation is frankly destroying society. It's creating a huge amount of anxiety, and the only way to tackle that is to have better conversations and difficult conversations. I think one of the things that happened in COVID was people stopped having difficult conversations. They didn't want to have them. They just didn't want to talk about it. I mean, very few academics have talked to me about the work I've done on COVID, which is completely bizarre because they all know about it. And that's cowardice, actually. And we have to be brave to have difficult conversations, difficult choices, which have to be made sometimes conversations around death, like you said, Hugh. And we have to create environments where we can do that. And if we don't do that, we will all pay the price.
I think that is the right moment to sort of wrap this up. I think if I was to sort of try and zoom out even slightly from the wonderful comments we've just had, I think, to me at least, what's most critical about this is it's not sufficient to have a conversation, right? A lot of people think they're having conversations when they're exchanging words or differing opinions. To have a conversation is actually to, as Hugh said, active. It's an active process. You have to actively be prepared to change your view. And actually something that I think came out of our conversations about what happened with the lockdowns and why basically we did not pay attention to what was going on is that people weren't listening, actively listening. And the important point was the course of action was not changed sufficiently in light of those conversations. So that's what I took away from that. Please join me in thanking our fantastic panellists for having this conversation this evening, and then join us outside for a glass of wine if you would.
Thank you very much, Gunesh.